stroke risk progression through combination of diabetes, hypertension, and cerebral vessel calcification using VMT energy model. Number 1355, September 13, 2025. Gerald C. Shu, EclaireMD Foundation. Category: Stroke. Preface: I want to share how my stroke resulted from progressive cerebral vessel calcification, built up over more than 30 years, and how I have tracked its trajectory over the past 14 years. Using the energy model of viscoplastic medicine theory, VMT, I was diagnosed with type 2 diabetes at age 45, 1992. For the first 2 decades, I did not control it well. My hemoglobin A1C once reached 11%. Prolonged hyperglycemia slowly and continuously damaged my blood vessels, including those in the brain. Between ages 47, 1994, and 56, 2003, I suffered 5 cardiovascular events, clear warnings that my arteries were under heavy stress. The pathophysiology of chronic hyperglycemia is well established. Persistent high glucose promotes endothelial dysfunction, arterial stiffness, and accelerated atherosclerosis. Advanced glycation end products, AGEs, accumulate and cross-link with collagen and elastin, reducing vascular elasticity. Oxidative stress generates reactive oxygen species that injure endothelial cells. Low-grade inflammation and dyslipidemia further destabilize vascular integrity. Together, these mechanisms progressively damage small and medium arteries, laying down the foundation for calcium deposition within vessel walls. By age 63, 2010, I finally brought my diabetes under strict control through lifestyle management. Over the past 11 years, from 2015 to 2025, my hemoglobin A1C has remained in the safe range, 5.9 to 6.8%, without medications. Yet the damage from earlier 2 decades had already left deep scars. Around this same period, I also developed severe kidney disease, neuropathy, and retinopathy, evidence that both large and small vessels throughout my body had been compromised. Aging played a constant background role. With time, vessels naturally lose elasticity and stiffen. My annual averaged pulse pressure, PP, after 2012 exceeded 40 mm of mercury and approached near 50 in 2024. Creating favorable conditions for calcification. Aging alters elastin and collagen, while chronic kidney disease disrupts calcium phosphate metabolism, both accelerating vascular calcification. Dyslipidemia, another frequent companion of diabetes, fueled atherogenesis and vascular inflammation. Hypertension added another layer of stress. Sustained high blood pressure thickens arterial walls, increases shear stress, and accelerates calcification. In my case, I was never formally diagnosed with chronic hypertension, which initially seemed contradictory, given that my imaging suggested hypertensive calcification. The answer lies in what medicine now calls masked hypertension, or episodic surges. Many individuals with diabetes experience pressure elevations at night, in the early morning, particularly during emotional stress. After exercise, acute hypertension is also common, particularly in those with vascular stiffness or small vessel disease, because blood pressure can rise sharply and remain elevated longer than normal. Since blood pressure waves are high-frequency wave, these BP surges are rarely captured during clinic visits, but can be detected with 24-hour ambulatory monitoring. Evidence shows that transient surges are not benign. They generate mechanical injury to fragile small arteries, especially in the brain where autoregulation is delicate. Over decades, these bursts inflict cumulative damage, equivalent to sustained hypertension. In my case, they acted as accelerants, compounding the injuries already caused by diabetes and aging. My unhealthy lipid profile worsened this burden further. Looking back, diabetes was the dominant cause of my cerebral vessel calcification. Aging served as the constant background driver. Episodic blood pressure surges were smaller contributors, next to my glucose waves, which are low-frequency waves, but powerful enough to push damaged vessels over the edge. Culminating in my first stroke on June 21, 2025. Imaging evidence, CT and MRI. My CT scan revealed scattered bright white deposits along several small cerebral vessels. Classic signs of vascular calcification. CT is the modality of choice for visualizing calcium, as it detects high-density deposits with excellent sensitivity. MRI, while less effective at showing calcium directly, demonstrated the consequences: white matter hyperintensities, small lacunar infarcts, and evidence of chronic microvascular disease. These findings are consistent with what the literature describes as cerebral small vessel disease, CSVD, a leading cause of both ischemic and hemorrhagic strokes in elderly patients. Radiologists often attribute such findings primarily to chronic hypertension. Yet my case demonstrates that long-standing diabetes and aging can produce an indistinguishable imaging profile. Integrating engineering and medicine. On September 11, 2025, during my first post-stroke follow-up meeting, I sat with my neuroscience doctor to review my CT and MRI images. For the first time, I could clearly see the underlying reason for my hemorrhagic stroke. It was not caused by a single sudden trigger only, but by the cumulative damage of more than 3 decades of type 2 diabetes, aging, intermittent episodes of acute hypertension, and the visible calcifications within my cerebral small vessels. This realization immediately connected me back to what I learned in Professor Norman Jones's MIT classroom in 1972, about nonlinear plastic responses of engineering structures under severe dynamic loading. After 5 decades, I now find myself applying those early lessons in engineering to understand my present medical condition in senior age. From a scientific perspective, my case is a clear example of the nonlinear, dynamic, irreversible, and cumulative nature of chronic disease. Traditional medicine often evaluates single risk factors in isolation. Hemoglobin A1C for glucose, systolic pressure for hypertension, LDL for cholesterol. Yet vascular calcification is never the outcome of a single number, or a single clinic visit. It represents decades of interacting stresses, biochemical, hemodynamic, and metabolic, gradually accumulating until the system fails. This cumulative effect can be clearly demonstrated using the viscoplastic energy model, VMT, provided that sufficient longitudinal data are available. From a personal perspective, I now see that my stroke was not simply bad luck. It was the predictable end product of the stresses my vessels carried for more than 30 years. Even though I have worked diligently over the past 15 years to control my diabetes, the damage from the earlier 2 decades had already been etched into my vascular system. The calcifications on my CT scan are, in essence, the scars of my past physiology. Data preparation. I initiated the collection of my personal health data, encompassing both lifestyle factors and primary biomarkers, in 2010. Nevertheless, the datasets only reached a sufficient level of completeness beginning in from 2012 to 2013. Furthermore, because many biomarkers require physician prescriptions for testing, the scope of my data collection was constrained. Consequently, the present analysis is based primarily on the more comprehensive datasets obtained after 2012. For this stroke risk study using 3 categories: diabetes, hypertension, and vessel calcification, I developed the following 3 equations. Diabetes type 2 risk equals the quantity of FPG divided by 90, plus EcG divided by 120, all divided by 2. Hypertension risk equals the quantity of high SBP divided by 140, plus PP divided by 45, all divided by 2. Calcification risk equals the quantity of real age divided by 70, plus normalized lipids, all divided by 2. Results interpretation. 1. Stroke index trajectory, from 2012 to 2025. Stroke index was extremely high in 2012. 152, reflecting uncontrolled diabetes, hypertension risk, and calcification. By 2016-2018, it fell to 89/90, indicating improved diabetes control and BP stability. After a rebound to 97 in 2019, the index plateaued between 91-94, 2020-2025. Overall, stroke index improved by 38%. 152 to approximately 94, but never normalized due to irreversible calcification. 2. VMT stress strain energy contributions. Total accumulated VMT energy is 736 units. Relative VMT energy contribution shares: T2D 41.4%, hypertension 32.0%, calcification 26.6%. Interpretation: diabetes was the main driver, accounted 41%. But hypertension and calcification together accounted for 59% of vascular stress, consistent with clinical history. 3. Cumulative VMT energy progression. From 2012 to 2014, sharp rise to 56%, reflecting past decades of uncontrolled diabetes. From 2015 to 2017, plateau at approximately 70%, stabilized by better glucose control. From 2018 to 2019, jump to 100%, aligning with calcification and episodic hypertension events. From 2020 to 2025, stable at approximately 97 to 100%, reflecting damage saturation with little new progression. Summary: most vascular damage accumulated before 2019. Post-2020 lifestyle and diabetes control slowed further deterioration, but calcification locked in a persistent baseline stroke risk. Conclusion: this 14-year longitudinal study demonstrates that stroke risk is not the product of one isolated factor, but the cumulative interaction of diabetes, hypertension, and vascular calcification. Despite strict glucose control since 2010 and stable management after 2020, the irreversible calcifications from earlier decades ensured that stroke risk remained elevated. From an engineering and medical systems perspective, my case highlights the nonlinear, dynamic, and irreversible nature of chronic vascular injury. It also underscores the importance of early intervention, While late control may stabilize progression, it cannot erase decades of prior damage. For patients and researchers alike, the key lesson is that stroke prevention requires not only real-time biomarker monitoring, but also longitudinal modeling of cumulative stress, such as the VMT energy framework. If I compare this quantitative research paper to many other published stroke studies, my work not only incorporates pathophysiological explanations, but also goes beyond traditional correlation-based statistics. It demonstrates causal pathways, cumulative, nonlinear effects, and irreversible damage through a systems-based perspective. This makes the study both scientifically valuable and personally authentic. Appendix: VMT methodology. The viscoplastic energy model VMT quantifies chronic disease progression, using stress-strain principles adapted from engineering materials science. Strain represents the observed health outcome, e.g., stroke index. Stressors represent contributing risk factors or influential inputs, e.g., T2D, HT, calcification. Energy is calculated as the area under stress-strain curves across time, reflecting cumulative and irreversible system damage. The model captures nonlinear, dynamic, and irreversible behavior. Unlike conventional linear statistics, this study applied 3 stressors normalized against physiologic baselines. 1. Diabetes, FPG, EcG. 2. Hypertension, SBP, PP. 3. Calcification, age, lipids. Longitudinal datasets from 2012 to 2025 allowed quantification of both annual and cumulative energy contributions, highlighting saturation effects and dominant stressors. For details, please search Health Talk with EclaireMD on YouTube. Disclaimer: this content is for educational reference only and not medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be edited or republished as your own.